David and I have been practicing together in Atlanta in a group practice for 26 years now. I first joined David in 1992, and really it's been an amazing journey in dentistry. And what we'd like to do today is really kind of not only give you some ideas on how we work together, what the team concepts are of treatment planning, but also sort of an idea of what our practice is all about. We really look at things always with a optimistic view. If you take a look at these cedars in Lebanon, looking up at the sky through the trees really is a big ordeal for us with implant dentistry in particular, and reconstructive dentistry, because very often that's not the look that we see. We sometimes see gray clouds, winds, and rain, and sometimes it becomes very, very challenging for us. And we're going to try to talk about some of the parameters we use to avoid those types of issues. Clinical decisions for David and I have not come just by working just between David and myself, but have really come by us working in a team. Ronald Goldstein, my brother Henry, and then over many, many years adding talented laboratory ceramists to the group like Pinkas Adar and Christian Coachman have allowed us to expand our opportunities and abilities to manage very difficult situations. More recently, we understood that in order to stay effective and to stay relevant, we had to adapt as an older office, and we brought in this last 6 months 4 new people to the office, 1 laboratory technician, 2 prosthodontists from Augusta College, and 1 restorative dentist who recently joined us, and we're sort of like the United Nations right now. We have Brazil, we have Egypt, we have Iran, South Africa, and I think Ronald Goldstein is from Atlanta. So our team has always been involved in trying to get the best that we can to help us and to move forward, but we've also been involved in a lot of education and research and collaborations with companies, Keystone being one of them. So our disclosure would take a month for us to read it through over the last 26 years, but if you want, you can take a look at this and read it for yourself. David?
So I guess for many of you I know, you know our focus, because of Ron Goldstein, has been aesthetic dentistry. And initially it was aesthetic dentistry as we knew it, crowns, bleaching, veneers, and it evolved to incorporate implants. Implants became a predominant factor in our office, and of course, one of the biggest problems from the point of view of aesthetics. So aesthetics around implants has really changed the way we look at things in the office. I'll get this out. So when we look at aesthetics and implants, implant aesthetics is really no longer about osseointegration. It's really predominantly about how it looks. It's all about aesthetics. And when we look at aesthetics, we tend to think about crowns. And you might refer to that as the white aesthetics, as Belzer did. But there's also a second component, and that's the pink aesthetics, as described by Furhauser. And you'll see the 2 of these really interface incredibly carefully. And the one is predicated upon the other. So when we're talking about aesthetics and implants, it really does incorporate much more than the white. These 2 indices give us a chance to evaluate it a little differently. We can score the white aesthetics. We can score the pink on the color of the tissue, the form of the tissue, the scarring of the tissue, the color of the tissue, and give it an actual number. And then it becomes a little more objective than us saying, it's a pretty good result for an implant. Remember, if you can tell that it's an implant, it's a problem. So it gives us this objective view. It's still not 3D, but it does give us a chance. So when you look at implant aesthetics specifically, I think you should realize it's not only about the white. Take it a step further and understand that the white interfaces with a very critical portion, the pink gingiva. And this meeting is really all about the pink. And the white really is predicated for its attractiveness on that pink. So this is the interface you want to see. It's the coronal aspect, the cervical aspect of the white, the restorations, the teeth, that free gingival margin just beyond that supports it from an aesthetic point of view. So it's the pink-white interface that you want to see in harmony. So let's look at a case that Maurice and I did some years back, about 17 years, as you'll see. Tapped it off, everything went in those days with temporary cement. You can see me probing it. And, I mean, 17 years, it's survived, it's healthy by all intents and purposes. If you look at the literature, this is a great success. It really is a remarkable success. We did bone graft, soft tissue graft, all sorts of things. The only problem we have with it really is it's ugly. And you have to realize when we talk about implants, ugly is a disease. It's a problem. And that's what we're trying to avoid. Think pink means don't, let's get ugly. So this is what she looked like. Every time I saw her in hygiene, it kind of disturbed me. Pretty porcelain, but it doesn't really look like teeth, and I felt really uncomfortable for a long, long time, trying to wonder, do I redo the case? How do I redo it? Can we graft it? I spoke to Mo dozens of times. Can I graft this? Can you graft it? Can someone do something?
That's when I said I may have to leave the office.
She's a particularly nice lady. And it bothered me, a very high-end nurse. And what you're seeing here is the interface not being there results in distorted tooth forms because we just don't have the normal pink architecture.
What's very interesting about this case is this is really showing you our, for instance, they say dirty laundry. 17 years, and in a way you say we've given a patient after an accident, car wreck, bone graft, tissue grafts, implants that remain in the mouth and functioning. She comes in for hygiene, she does a good job, she is a nurse, she's aware of her situation. What's also realistic, and I think we really as a profession need to really look at this, is for the surgeons out there and for the restoring doctors out there, the changes that occur around loaded implants over not 1 year or 2 years, but over a decade, over almost 2 decades. It's not something that's static. It continues to remodel, it continues to change, and very often we have remodeling of the bone underneath after loading, and very often even without any periodontitis or periodontal disease. And then of course the tissue changes, the volume, the thickness, and the amount of keratinized tissue. So very often we're looking at many different factors.
Lots of factors. I mean, just look at the tissue, you're seeing pink, but it's really distorted pink in form, in shape, in color. It's pebbled. It just doesn't look pretty. So we kind of racked our brain, took the bridge out, looked at it, and looking at the ceramics, which was actually beautifully done, thinking it just needs something. I talked to Pinkus, asked him about putting on pink porcelain onto this. And he told me, are you crazy? After 17 years, it'll blow the bridge up. Guy was in the office, and we were talking. He's another ceramist. And he came up with an idea. And we actually decided to replace that transition zone, recreate it, put it back into harmony. And what you actually see here is we just outlined on the teeth, initially in red pencil, where that pink transition zone should go. And then what we did is we roughened this area coronal to the black line, just with a fine diamond, a polishing diamond. We etched it with hydrofluoric acid. We put silane on, dried the silane, put on unfilled resin. We put some pink flowable composite on top of that, cured that. And then we put hard, more viscous composite on top of that, squeezed it back up into the mouth, and you can see how it wrapped around the soft tissue. We took it out again because it comes in and out easily, and we trimmed it all away, and you can begin to see the white-pink interface over here, how it's beginning to change the tooth form. Look at this tooth form down to this tooth form. So that transition zone is all important. We polished that up. And it's not a new idea. You'll see it goes back in the literature many, many years. But we did publish fairly extensively on this in 3 articles available to you on Dental XP. Download them in PDF around about 2007. We made sure that as we added this material, it was cleansable, and please make sure of this. We document it, we show it to the patient, we put it on their iPhone, and we know that we did our job teaching them to do it. They've got to now do it. And you can see replacing the transition zone. This is what she looks like now. This is the same day, probably this particular day about an hour and a half later. Same bridge. And you really want to get a perspective by the beginning of the appointment on your left and the end of the appointment on your right. And putting that transition zone back into harmony, you can see a dramatic change in how this lady emotes, reacts, and involves herself in life around her.
The way we work as a team really is about us looking at a situation like this and trying to see what the possible solutions are. David, before going to the prosthetic solution, actually came and we sat down together with the laboratory technician and said, is there something that we can do to add bone or tissue to alleviate some of the issues we have aesthetically? Can we do something that is predictable surgically to be able to do what David did restoratively and prosthetically? And honestly, with implants already there, the ability for us to move that bone and tissue vertically and to fill that interproximal area was really impossible from a surgical standpoint. So the only solution here was a prosthetic one.
And as you can see, certainly from the aesthetic point of view, a very effective prosthetic one. And the idea is just get that transition zone back. You can see different views of it. And then looking at it at 7 years, and I know your immediate answers, or your immediate question is, this is pink composite. I mean, is it going to last? And if it doesn't, just scrape off the surface. This one, actually, she went on an all-vegan diet, and 18 months after this, it was discolored in all sorts of berry juices. And we just took a fine finishing diamond, took off the surface, put unfilled resin on it, put new resin in, patted it in the mouth, trimmed it up, and she's now at 11 years, and a quite changed lady. So we really do more than just put teeth in. We change the way these people interact with life. So when you look at, a restorative recipient site, this was a prosthetic solution to it, because we just didn't have surgical. We didn't know of a surgical, and we went through all sorts of things. Let's look now at surgical for a moment and spend a lot of time with you on looking at different ways of handling surgery. So let's look at the interfaces. We talked about that between the teeth and the pink gingiva. Realize that that complex of teeth and gingiva fits very peculiarly in a very defined space into the lip relationship. And that is also part of what we do. So we will do things to line up the tissue and develop that interface, tissue and lips in harmony. And then, of course, you get dentofacial, which is really a little out of our purview, but is always taken into consideration in everything we do. And you'll see right up to the last case how we utilize the information we get from the whole face in how we develop the individual tooth. So kind of interesting. And that interface management really goes between bone, teeth, lips, gingiva, and face. And you've got to really manage all of those different aspects of the interface for success, which we said is aesthetics as it goes to implants. You can see by the time we replaced this particular tooth, it's difficult in this case is actually exactly the same age, 17 years, and difficult to tell that that central incisor is actually a poorly placed single crown. And we got around this one with surgery. We added surgery, we added soft tissue in bulk and developed it.
So what we ended up looking at over a period of time for David and ourselves, as well as Stephen Chu and Dennis Tarnow in New York, is we started thinking about this dual zone concept. A lot of the cases we were doing were extraction cases. We were seeing some good results, some questionable results, and then some results that we weren't happy with. And we developed this concept with Dennis and Stephen called the dual zone therapeutic concept. Dual zone meaning, what do we do in the bone zone, the bone around the implant? What do we do in the soft tissue zone, that area that encompasses the area above the implant and where the restorative space is? And when you take a look at what it is by definition, really if you're looking at the bone zone and the tissue zone, that bone zone is what encompasses the root, or if in fact an implant is placed in its position. And that area that encompasses about 3 millimeters above the bone, 3 to 4 millimeters, which would be the soft tissue zone. The tooth and crown zone is that area that David mentioned earlier, is the white part of the aesthetic puzzle. So whether it's an implant or a tooth, we're going to have a bone and soft tissue zone that transitions to that restorative space. So what do we have control over? What are we going to focus on? What David and I would say to you by the end of the day, what should you get out of it is, this area is what we have the ability to either maintain, augment, preserve, or destroy. We have to come up with a plan to manage it, and invariably it comes down to only a handful of millimeters. You're not looking at something that's going to be seen up in the vestibule. Patients won't see it. At the top of the tooth form, you're not going to notice a difference as long as the ceramic's nice. You're going to notice this transition, that area that goes from the bone to the tissue. That 4 to 5 millimeters is going to be the difference between an aesthetic restoration or one that is not aesthetic. If you take a look at a case like this that we had done with a Prima implant, we use a zirconium abutment, we're able to get a very, very nice final restoration on this implant, but not only because of the zirconium and the ceramics, but more importantly, in a very highly scalloped gingival architecture, being able to maintain and preserve that architecture throughout the procedures that we employed. So the focus for us is really on this transition, the transition from the bone zone to the tissue zone. And you can see here, when we're not capable of managing that, we run into these types of real-world problems. And as David says, we may not say it, but ugly, or I would say unesthetic, becomes a very big issue for the patient. As a matter of fact, maybe even more so than a fistula. These patients aren't happy. This transition zone, where you see the white line for the bone and the red for the tissue where it's supposed to be, has not been managed appropriately by the team, by the whole group, whether that be the surgeon or the restorative dentist or even the lab. Sometimes laboratories can overbuild contour with the prosthetics and by the abutments and put too much pressure on the tissue, causing recession or discoloration. So aesthetic failures can occur, and they occur in this transition zone. So think of it, when you leave today, say, I know what the transition zone is, that's what I'm going to focus on. Our team certainly does that. So let me share with you a case that we inherited. This was kind of interesting. David and I had a very lovely patient that we did 2 lateral incisors. She was congenitally missing. She was 30 years old. And she said, you know, guys, I have a sister in LA. She had some work done. She wants a second opinion. Would you be so kind as to see her? And I said, oh, she's a really nice young lady. It's her sister. Yeah, let her come in. And the sister comes in, and this is what she looks like. And she said she had an accident, and this was done 12 months ago. She's 35 years old. She's not married. She says she can't smile anymore, and this is not what she expected from the final result. David talked about that previous case we did 17 years earlier and about how we ourselves didn't like the result, even though the patient was actually, as a nurse, was accepting of it. This patient said, I was never told that this was going to be the case. I was told I was going to get teeth. I was going to get teeth that look like teeth. And in a patient with a high lip line, that has to be part of our overall treatment design. So we sit there together, and David and I say, well, what do you think we can do here? What kind of solutions can we employ? But before we think of solutions, let's think of diagnostics. Let's think of digital smile design. Let's think of mock-ups. Let's think of where the lip is. Let's think of proportion, golden proportion. Let's do a wax-up, whether it's an analog wax-up the old school way or whether you want to do a digital wax-up, whatever it is that you want to do to get on the same page with the patient and the team that you're working with. In this case, David, Christian Coachman in the laboratory. Everybody needs to know what is it that we're looking to achieve. And very often, all we're trying to achieve is balance. By the time you see a patient smile, you don't want to see a significant difference between one side and the other, one tooth and the other. We're looking for proportion. Harmony and balance is something we mention all the time. So when we sit together, and David and Christian sitting there with me said, listen, we really don't have that here. Well, the first thing you're going to look at is before you jump into the pool, let's find out what happened here. Patient claims to have had a bone graft done from the hip, soft tissue surgery, followed then by implant placement. What were the possible reasons for failure? And by the way, if you look at this case like ours, it's actually successful. There is no infection. Patient has no pain. She's functioning on these teeth. If we look at the original 10 rules of what is failure and success, this patient passes, yet she's unhappy. So what was the possible issues where this team in LA didn't achieve the desired outcome for the patient? These are the 4 things that we constantly look at as a group, and I think that that's something that we should all share. We may all treat the patient differently. Everybody in this room is going to probably use a different concept, maybe different numbers of implants, maybe do a conventional bridge, maybe do artificial gingiva. We should all agree on the diagnosis. That should not be something that we make an error on. So always take the time to diagnose. Where's the bone? Where's the infection? How much tissue do we have? What's the thickness of that tissue? Can it withstand what we're going to do surgically? The case selection. How many implants? Is it a high lip line case? Are we going to be in the aesthetic zone? Unrealistic expectations. I would say that's, to me, maybe number 1. Unrealistic expectations of the patient or team members. If David says to me, I expect you to be able to build all this soft tissue for me and make it look great within the smile on a patient who got into a car accident, I would say maybe that's unrealistic that it's going to go perfectly well. Maybe we have to have a different concept of what that is in terms of expectations. numbers of surgeries, cost. And of course, number 4, inadequate treatment design. What should be the design of the case? Should it be artificial gingiva? Should it be conventional bridge work? Should it be 2 implants rather than 3? We look at the case and we analyze, and you cannot do it 2-dimensionally. Those days are over, because 2D lies, 3D is the truth. And we still see people showing cases, including ourselves, say, take a look at this radiograph and it looks great, but if you looked at it on a cone beam CT, you wouldn't be as impressed. We have to then overlap that radiographic image 3-dimensionally onto the patient's smile and say, where's the implants, where's the bone, and what's the support for that soft tissue? And once we do that, we have to then be realistic. Take off the bridge, take a look at the abutments that are there. How much tissue do we have? How close are these implants? What is the position of the implants? Were they placed using a guided approach? To me, I would look at a number of different factors here. The probable issues were maybe there wasn't an agreement on numbers of implants. Maybe it wasn't guided. Maybe the implants are too far labial. Maybe not enough bone and tissue support. There's a lot of different possible issues here. And if we make even one mistake in a case like this, we're doomed to failure. So to me, this is a diagnostic failure. And David and I have to sit together and say, okay, David, what is it that would give this patient harmony? And David goes ahead and gives us a smile mock-up that we use for guidance.
So we really want to define where that zone must be. And remember, our first big issue is it's all beneath the upper lip, so it's on display. I can't use prosthetic means here because I'm not going to get a decent interface between the pink prosthetics and the remaining pink tissue. So we're going to have to look at the surgical alternative as we showed you in that single unit. And our first real issue was, let's see what we need. And we developed a set of temporaries, not with ideal tooth form, but acceptably good tooth form, and use that as a guide. Now what do? Can we measure from the height of the papilla to the remaining bone and anticipate from the literature where we can expect the soft tissue to be? And we can do that. We know, for instance, that an implant-to-implant relationship, we can't anticipate much more than 3 millimeters vertical height of papilla. So if this is the bone, you should be able to get the papilla down there. That's not going to work. You look at the relationship between a tooth and an implant, you see it works much, much better, because it's dependent on the height of bone on the adjacent tooth, and that's 4.5, and it will maintain that papilla. And then, of course, a big plus advantage for us is Pontics. You can have 6 millimeters of soft tissue of a papilla with no bone until 6 millimeters from the tip. That's a huge mechanical advantage to us in planning.
So if you take a look at this for me as a surgeon and for the team, David and Christian give me a mock-up, and I can make these measurements from their mock-up. They're saying, Maurice, we need our teeth to look like this. Can you surgically move tissue into that area? That's really the question. I can either say yes, no, or I can say maybe. And that really becomes a very critical aspect. Knowing where the bone is, we already have some crestal bone loss down to the second thread, but even more disappointing, when we raise the flap on these, this is what the implants look like. Remember I said to you, be careful of evaluating your cases on PA films and 2-dimensional films, because these implants are stable. They're not infected, there's no pain, and they're functioning. But yet, threads are exposed, a lot of the bone that was augmented is remodeled. It's been 12 months since loading. So we have to decide what are our choices, options, and solutions. Let's really consider that, because in this audience, I'm sure that we have 3 different types of people in it. I call them the red, the blue, and the pink. How many oral surgeons in the room? Wow. I told you, we have a lot of red. You got to come with your Tiger Woods red shirts on when you come in. I showed this case to the New England Academy of Oral Surgeons a few years back, and when I asked them what they would do, most of them said, I'd remove the implants and regraft. Interestingly enough, just as a funny aside, David walked into the room when I first met her, and David, as you don't know, maybe don't know him, some of you should, is very, very funny and debonair, and he has that great South African accent. And he says to the patient, oh, honey, we may be able to redo it. And she goes, how would you do that? It was just, we take some bone from your hip. And she said, but I already had bone taken from my hip. He goes, of course you did. I was talking about the other hip. How many periodontists in the room? Okay, so we got those of us in blue. Periodontists, many of you say, hey, you know what? Maybe I can mask this problem with soft tissue, or maybe a combination of bone and soft tissue. And maybe I can kind of create something that the restorative dentist can use. How many restorative dentists, laboratory technicians, prosthodontists in the room? I know you're going to dominate. Like David and Christian, they would say, hey, I think I can do this with artificial gingiva, pink porcelain, pink composite resin. A lot of it comes down to what is our training, what are we comfortable in, but it should come down to sharing of the load and responsibility. I believe that that's critical, not only in the same office. I work with dentists and people outside my office and really great restorative colleagues. We have the same discussions even if they're not in my office, even if the laboratory is not in Atlanta. Same conversation should be had and can be had digitally. I decided, and I spoke to the patient, get an idea of what she was willing to accept. She just, at 35, said, I can't have the implants taken out and go through this again. We have to realize we're dealing with a human being. There's a human factor. She said, I got into the accident. It's taken 18 months of my life. I don't want to go through taking them out, going through another bone graft and everything else. Is there anything else you can do? I said to David and Christian, I said, listen, it's possible that we can graft the facial aspect of those implants with a veneered and GBR graft and then double up on that with soft tissue. And if we don't re-engage the implants, we can be 6 millimeters from the bone and still fill that interproximal space. Will that kind of do it for you? And I told the patient, it's not 100%. I'm not sure we're going to be successful, but I believe this gives us an opportunity. So we took off the abutments, placed healing abutments, and then we took soft tissue from the patient's palate, both sides. We needed a lot of tissue. And then we coronally advanced the flap for the surgeons in the audience over the healing abutments. And this is something that we published on in 1995 for this very indication, because we had some of these cases, and we saw that we needed vertical height. And what this shows you is basically a diagram. We used to put cover screws. Remember those days? Well, when you place a cover screw, it doesn't support the vertical position of the flap, so we lose height. So we started placing straight, non-flared healing abutments, and we would add tissue to the labial and vertical aspect, and then coronally advance the flap and suture it all the way to the lingual aspect, gaining vertical and horizontal volume. And this article is on dentalxp.com, and you can download it as a PDF. We placed 7.0 PTFE sutures. We left them in the mouth for 3 to 4 weeks. Patient went to see a very nice, very good periodontist. He was teaching at the time at the USC. And I said, Mark, I'm sending you a patient, you take the sutures out. And Mark calls us up and he said, I see your patient, I'm taking the sutures out, what do I need to know? I said, do you see anything that looks like metal? He said, I don't know what you're talking about. I said, good. Patient comes back to Atlanta 3.5 months later. And these implants are sleeping underneath the tissue. We took a case that had multiple implants that had lost all this volume of tissue, and because we changed the treatment design from multiple adjacent implants to a conventional bridge with Pontics, we have a different volume of tissue that can be supported in a distance from the bone. That chart that we showed you earlier becomes a critical factor in our decision making. So David takes this off now. These ovate pontics, in fact, during the edema from the surgery, have helped shape the contour that you're seeing underneath that bridge. So the tissue molding aspect of working with an ideal shaped temporary bridge that was designed by David and Christian was imperative to us getting the results that we see here. So now the question becomes, patient sits there and says, can we go back and use the implants? How many in this room would go back and open up and use the implants again? Anybody? Nobody's that brave. How about 2 of the implants, not 3? I see a few hands up. This implant over here and this implant over here, leave this one asleep. How many like that idea? A lot of people have been going to CE courses. That's good. We had that discussion.
Long time.
Patient came in. David said she wants to know if she can use the implants. She says they're there. She paid for them. I said, does she like the way it looks? She loves the way it looks. She doesn't want to change anything. I said, really? She says, what do you think? I said, those implants had dehiscence on the labial. They were projected labially. They would have to be with angulated abutments. They would put pressure on the tissue. You uncover the implants. And I said that in front of the patient and her sister. And her sister turned around and she goes, I think we will leave those implants asleep.
So David and I, look on my face.
David and I said, you know what, maybe that's a good idea. The chart that you saw earlier was a chart that we published first in 1998. It's been published twice again in 2007 in the IJPRD. It really was one of those things that we did over a number of years, starting in 1996. We would take 30-gauge reamers, we would take rubber stops, we would probe in different situations down to bone, and we take those measurements on ideal cases, and we basically collated this over 137 cases, implant cases, pontic sites, multiple implants, and that chart was sort of a painstaking measure that we now utilize as a daily regimen in almost all our cases. One of the most important bits of information from this 1998 article was rule number 1, for a single implant, especially in the aesthetic zone, it is the interproximal height of bone of the adjacent tooth, not the implant site, but the adjacent site, these red lines, that limit papilla dimensions. So remember, when you're looking at a case like this tooth going to be coming out, it's not the bone around the tooth that's going to limit your height of the papilla. It's the bone on the adjacent tooth. Always look at the adjacent bone heights, and it really gives you an indication. When David comes back to restore the case now, he can go ahead, realize that underneath this tissue are sleeping healing abutments with a very large thickness of keratinized gingiva to support his pontic sites. We took a patient like the one we started with that was transferred prosthetically, and we went ahead and put these implants to sleep, removing those abutments and building that tissue up to the point where David and Christian can develop the aesthetics. All of that tissue reconstituted because of the change from multiple implants to multiple pontics. A conventional bridge from an implant-supported bridge, 6 months on the day of the final cementation, and you can see how that has played. Most importantly, from a smile perspective, in black and white, you can see that it certainly, the interface wasn't developed well. We talked about interface development. This interface has now been developed through an alternative means, done this time surgically, not prosthetically. Periodontally, this lady has now the ability to smile big and to manage to have soft tissue fill in those critical areas. So for reconstructive cases in our office, it really always is about interaction, about developing a proper treatment plan.
So again, treatment plan is those critical interfaces, relating them to one another, knowing what to expect from one of them, and knowing what you can achieve at any given phase when you have any aberrant forms in this. How best to treat it? A young gentleman who got involved in some traumatic incident, you can see he looks like he's fractured this tooth, and they stabilized them for a while, and we're looking at bridges, but these teeth are good, and you know, taking out the tooth, what a pontic's going to look like. So I'm talking to Mo and going, can we do an implant on this? Wouldn't an implant be better? We don't compromise the adjacent teeth, and perhaps we'll retain that interface that's also critical, because you now got this interface, that this interface is now got to look exactly the same as. Can you, as a surgeon, do that, Mo? Or do I have to look for alternative ways? We start to look, and you begin to get a sense that there are some significant fractures, and the result is sequelae of the fracture. And then you look across as we raise the flap, and you can see the amount of bone loss associated with the fractures in that tooth. So he's really got his work cut out for him. Is this, you know, throw in some sort of granular graft, close it up, and put an implant in that? Or is it much more complex than that? How much skill does this require? Does it fit into his skill set on a predictable basis, so that when I get it, I can work with an interface that is really pretty good?
It's a daily situation in modern clinical dentistry. We're dealing with cases we used to treat with conventional restorative dentistry, and today we're always thinking implants when possible, especially a young gentleman, 30 years old, has an intact dentition, really virgin and intact dentition. A lot of times we're seeing patients come in with a PA film, or they come in, as David showed you, with a fairly intact gingival display, and we're thinking immediates. Take out the tooth, I'll put in an implant. I may think that at times we may be a little bit cavalier. This patient came in from another practice, and the dentist in other practice said that he would extract the tooth and put in an implant immediately and temporize it. I looked at this radiograph and I said, David, we need a CT. This is now almost 15 years ago. And when we took the CT, I realized it was impossible that we would be able to do this case with an immediate placement. Too much bone loss, significant damage to labial plate, tooth comes out, big defect. And now as a surgical standpoint, now I start thinking to myself, how big is this defect? How far are the walls apart? And for the surgeons out there, that's typically what I think. When I see that I have limited walls for regenerative cells, when the walls are far apart and the dehiscence is very large, when the very large percentage of the bone that's going to hold my implant is going to be grafted bone, I typically look for a autogenous source of bone, and typically a block. Ramus is typically my #1 source, what I go to because of minimal morbidity. We do intramural penetrations, we prepare the site, we take the block, and we secure it, and I'll show you that in a moment. As a rule of thumb, I have these two concepts, and it's not, again, I said, there's many people in this room, every surgeon would probably do this case completely differently. As long as the diagnosis is the same, depending on that skill level and experience, going to get a good result. For me, I just simply say, I use guided bone regeneration, membranes, particular bone, synthetic or cadaver bone. When there's adequate bony walls that remain to support the space for regeneration and allows access for cellular ingrowth. When it's narrow, when I have a lot of walls and a lot of vertical walls to support it. I use a block graft typically. It's not something that I use, I'm using less and less. I would say it's a small percentage, less than 10%. But I use it best for critical size defects. When the percentage of the graft, the large percentage of the graft, is going to be what eventually supports my implant restoration. So this is what I would use in those indications. So here I take my graft from the ramus, I fit it to shape the deficiency, and we're going to go ahead and do something similar to what you see here. Small intramural penetrations. Today we even have growth factors, whether they're blood-borne or recombinant forms like BMP2 or PDGF. We place it in place. We'll then go ahead, place 2-point fixation, something that Mike Picos has taught me. And then around the periphery, we'll add some particulate bone, and on top of that, a resorbable collagen barrier. So this is what you're seeing here is pretty much identical. As a matter of fact, the video from Console Pro was made off of these images, and we place a collagen barrier over the top, and then we coronally advance the flap. We use PTFE sutures so that they're non-wicking, they stretch, and we don't have any issues about leaving them in place for a period of time. And one of the reasons that we like to graft beyond the alveolus is because of this very critical study that was done in 2005 by Grunder and Grassis. They published this in the IJPRD, and they said buccal bone thickness is key for aesthetics. We started our lecture by talking about aesthetic dentistry, and aesthetic dentistry including implants. So for David and I, this was critical. We look at this and say, in his paper, Dr. Grunder said when he came back into many of these cases, he had this kind of funneling around his implants at the neck. And he said that when he built out at least 2 millimeters of bone beyond the buccal aspect of the implant, he didn't see this type of dieback and remodeling. So whenever possible, you have 2 things that I would suggest. And I think it's better for the restorative dentist as well, David. Number one, we like to place our implants. We're going to make an error. If we're going to make an error, I'm going to make the error towards the palate, towards the lingual. If you want to make a mistake, lean towards the tongue. Don't lean towards the lip. For any of the surgeons out there placing your own implants. For the restorative colleagues, if you're more lingual, you have a chance of having a screw-retained restoration more than likely, as opposed to having to deal with a very significant angulation and maybe a cementable restoration. So this is a very, very critical article, and I think whenever possible, it also allows us to build the bone and maintain 2 millimeters of protective bone in front of that implant. 4 months later, patient comes back in. I think that we've done a good job with our bone graft. We kept it asleep. With block grafts, I like to come in about 4 months, and then we'll go ahead and we'll place our implants. This video and many others are on Dental XP. I'll just show a little part of it. We happen to have restored this with a Keystone Prima implant, and this is how the patient came back in. We're going to make a slight palatal crestal incision to expose the block. And I'm going to tell you right off the bat, I always tell my patients that in the aesthetic zone especially, even if I did the graft first time, David knows this, we talk about it all the time, I always tell the patient at second stage or at implant stage, I'm almost always going to add another graft. It may be some more bone, maybe some more particulate, GBR, it could be soft tissue. But always be prepared to add bone again or tissue again at that second stage procedure. We take out the fixation screws, we go ahead and we drill the implants, we put the direction indicator, we make sure we're lingual, palatal, so we have a screw access that's going to be lingual, and we start the process with the Prima drills. And today, really, the next generation or iteration of this system is the Genesis, which we'll touch upon later on in our lecture. So here I can go ahead, place the implant. I try not to oversize my implants these days, so typically for me and David, I would say our implant sizes, 80% of them are going to be about 3.5 to 4.5. I don't use a lot of very wide implants unless they're in the molar areas. We're going to place the implant. Remember, this was a very large defect. The key aspect of this, by the way, for the surgeons is the interproximal peak of bone of the adjacent teeth, because this is a purely type 2 defect. There was no vertical component. So I don't have to worry about the papillas here, because the teeth on either side are going to support my papillas. People always think about making these very small flaps because you think you're going to ruin the papillas. Couldn't be further from the truth. If the bone is there, there's no reason for these small flaps that many people are doing. We're going to release the flap. I'm going to place a slow resorbing graft material. This could be BioOs, it could be synthetic bone graft, it could be cortical allograft material. And over the top of that, I'm going to place a membrane, and then over the top of that, I will add tissue, because I have an opportunity of thickening. This is a gentleman who had a very large defect, and I'm overbuilding. And I want you to remember this case only for the fact that I'm going to, a 30-year-old gentleman, hopefully going to have this implant for the rest of his life, I hope. I want everything on my side to be done correctly so that I give David and the laboratory in our office the best opportunity for success. So a slow turnover product that will stick around, won't resorb, and a thick connective tissue graft. Today you could honestly use acellular dermal matrix as well. I used autogenous tissue in this case. I can then come back, and even at the uncovering of the implant, rather than tissue punch and throw this tissue into the sewer system, I can actually de-epithelialize it, place a straight healing abutment, and place it right in this gap to give us even more thickness. And this is an added dimension. Try to use as much tissue as you can. I remove any muscular attachments, frenum pulls from the area, do this with a laser. I want to give David a pristine area to work his magic for tissue molding.
So, initial phase, you're putting in a formed healing abutment that allows you to slowly develop a semblance of normal tooth form, and not the exact same as the adjacent tooth. And then we take an impression and we really copy the outline form of this tooth in 3 dimensions, because we're going to allow the form of this tooth to mold this tissue into the shape. And the key in this is, as you can see, Maurice gives me more than enough, knowing some of it will resorb, and giving me space, running room, to utilize all this, because this material is moldable if you develop the optimal or same as the adjacent tooth. And this tooth gives me a good guide. This is as we put it in that day. You see how this comes out before, anterior to it. And once I've got into nice form, I'm going to take a final impression, not of the location of the implant. We already know that. We've got it from a temporary impression. But I need the form of the tissue exactly, so the lab doesn't mess that up. The easiest way for us in these early days was just to put in an impression coping, use some type of flowable or relatively less viscous composite, get it in there to capture the internal aspect of the site, cure it, and then take an impression. And then we have an option to make some form of restorative endeavor, the abutment being the first component. We know that the gray of abutments has always been a problem. We've tried a multitude of different things. At this particular stage, we were using titanium abutments. And in this one, we used a titanium abutment. And you can see how this interface development has been reconstituted, redeveloped. And remember, it's actually a pink-white interface that's so key, but it's a transgingival interface. It slips down underneath, and as it goes underneath, it actually helps form the harmony in that pink. We're into options then. You can see we're already moving, knowing that we don't want any bleed through, so zirconium is an option, and also anodized abutments. And you can see early days of anodized were in a yellowy orange color, and now you can see one which absolutely makes sense. I mean, the tissue is pink, so let's think pink. So we're playing with pink now much more commonly. And again, as we put it in, you can see the tissue now beginning to form around this, becoming a very acceptable relationship as compared to the contralateral tooth. And this is at 1 year. This is now at 3 years. You see continued development of that soft tissue and the single unit restoration on it.
So you can see where we came from with a very wide distance between the bony walls. This is about 7 millimeters here and about only 3 millimeters at the apex. Really building this up. This is very thin bone in this area, being able to do this and circumvent the problem using both bone and soft tissue augmentation, giving David and the laboratory the opportunity to shape and mold the soft tissue. And then even with full thickness flap, lifting the papillas up, you can see because this bone here and the interproximal bone on the adjacent natural teeth allowed for this papilla to reform on either side. So remember, if you're going to avoid a papilla tunnel or make a mini flap, only do it if you've had damage to that bony wall on the adjacent teeth. Otherwise, really, I don't believe it's necessary. So this is a case, David, talk about what an interesting situation this presented to us.
This is an interesting fellow sent to us by an orthodontist in Dominican Republic who'd been doing some orthodontics following a polo accident on this gentleman. And he was trying to erupt this tooth, which, you know, is part of the literature from Maurice 93, and trying to develop the bone around it. And as he's erupting, you can see the kind of soft tissue response. He's bringing it a little bit out of the bone, if that bone was ever there. And he has a resultant issue that's a major problem. And he wants to know, can we put an implant in there? If we say, can we put an implant in? Of course we can put an implant in. But can we get the transition zone in this single unit on this side to resemble this in any possible way? And we sit together and Mo, what's in your armamentarium to pull this off?
This is a very nice man. This is a typical situation. You can maybe get referred if you're a surgeon out there, you get a referral from a restorative colleague. One of the things that I always like to look at is I look at the quality of the soft tissue over the regenerated area. You can see I have no attached keratinized gingiva remaining. I have a tremendous amount of recession, several millimeters, but also recession on the adjacent teeth. I always like to point that out as well, with a very highly scalloped gingival profile. So you have a bunch of things I like to point out to David and the team, and I say to them, I want to know where the interproximal peaks of bone is. I want to look at the CT, but before we do anything, we need tissue here. So we're going to go through a transitional phase, staging the case. Tissue first, bone second. So David.
And you can get an idea of this actually. Just draw a line for yourself and realize the volume of tissue you need. So we're going to try and fill this up and get good dense tissue so that Mo can go under again and then develop the bone. And I was in Sicily and he called me and he said he's going to be out of town. When you get back the day off, do some surgery. I went to the tuberosity because we have dense tissue that really has very little fat. And we can take that tissue in substantial bulk and bring it in here, shape it in like you would shape a block graft almost because it's that dense, and put it into this area and then suture it up over, filling the area, not trying to coapt it because it can lie in there and allow the tissue to epithelialize across it. And you can see the change in height. I mean, you're going from there to there. And all I'm trying to do is get him enough tissue to allow for bone support. And you can see done reasonably well, but it's not enough to do anything with as yet.
Actually, this is perfect for what we intend to do. Think of it from a surgical standpoint. Any surgeon in this room would say, boy, that's good stuff to work with now. David provided this patient with keratinized, dense, soft tissue that can now be functional in a flap that would manage the bone defect, because we know we have a very significant bone defect that needs augmentation, but we now have soft tissue, healthy keratinized gingiva that can cover my bone graft, minimizing the complications that can occur when we have poor soft tissue quality over our flaps, over our bone grafts. So 4 months later, we schedule second surgery. It'll be a block graft and a CTG combination. On the adjacent teeth, you see the recession. We're going to attempt to graft this. This gentleman didn't want tissue taken from his palate. I liked it also because I'm going to show you a little bit of a unique procedure, technique that and Howie Gluckman published on just a few years ago. But we're going to take bone from the palate, so I don't want to have to take bone and tissue. So we're going to go ahead and do root preparation using tetracycline paste for 3 minutes. And we're going to raise a full thickness flap, and we're going to harvest bone from the anterior palate. We're going to take about 4 to 5 millimeter cores from the palate. We published on this, called it Palatal Bone Block Harvest, and it was published in the IJPRD in 2016. So this is harvested from the palate, and basically what it allows me to do is use this 6 or 7 millimeter diameter core that I'm going to use, that's going to give me a tenting screw with the advantage of autogenous bone attached to it. So I screw this into the palatal bone, and it projects out and it fills horizontally 8 millimeters, and then buccolingually about 5 millimeters. I then add a mixture of autogenous bone and cadaver bone mixed with PRGF, so a growth factor, blood-borne bioactive material, around the periphery. And then on top of that, we're going to use a membrane. Now, this palatal bone block was published in 2016 in the International Journal of Peri and Restorative Dentistry by Howie Gluckman, Jonathan Dutoit, and myself. And this is really for maxillary cases where you're in that area and you have a cone beam CT that you can evaluate the bone on the palate, making sure you avoid the roots of teeth, making sure you avoid the floor of the nose and other anatomical landmarks. This is for surgeons that do a lot of this type of surgery. I wouldn't do this if this is not your specialty. Over the top of the graft and the particulate, the block and the particulate, I'm going to place the fibrin membranes from the blood. So this is a growth factor induced fibrin or originated fibrin membrane. Over the top of that, I'm going to place a drapable, non-cross-linked collagen barrier. This is the Symphony membrane from Salvin, and over the top of the teeth where the roots were exposed and we had a recession, I'm placing Oroderm, or acellulodermal matrix, that I hydrated as well in the blood of the patient, the growth factors of the patient. We then suture this, coronally advance the flaps, and we cover both the bone and the soft tissue simultaneously. David has the patient in a resin-bonded retainer throughout the healing phase, and this is how the patient goes home. Patient comes back. This is at 6 months. I wanted to see the patient at 4 months. I really prefer it with some of these small blocks, but because there's a GBR as well, I'll wait 6 months. This is what the post-op cone beam CT looks like. You're looking at the nasopalatine canal. Here's the screw, minimal resorption, and look at this nice bone that we've developed on the cone beam CT. You can see it even in 3D, that bone and particulate has been rebuilt. That area now has bone of significant volume for us to be able to place an implant. What's great about these cone beam CTs as well is that you can also analyze the interproximal peaks of bone and get an idea of the support in those areas as well. Axial images, take an implant from the library, and we can place it in. Now, I want to do as minimal damage to what has been reconstructed as possible. So when I'm coming in the next time to see this patient, first of all, we're very happy with the response of the tissue. Remember, there was no keratinized tissue to begin with here. Now we have an abundance of it. So I want to do a minimal amount of dissection. When we take the cone beam CT, we're going to use a guide from a 3D printer in the office. I punch through the tissue, but I don't throw it away. And I do a stab incision because I got to remove that fixation screw. So there's the fixation screw, and I can take it out without a major flap. I can feel it, I can see it, I can measure it from the cone beam CT, I can feel it with my finger. So once I can take this out with a minimal stab incision, it's 1 stitch. I de-epithelialize this little bit of tissue, which is about 3 millimeters in depth. And rather than remove this tissue, I can roll the tissue into a tunnel and add even more thickness to my keratinized gingiva. Take every opportunity in this transition zone to overcompensate, overbuild, because what I've been seeing, what David and I tried to show you earlier, is over years, not 3 and 5, but maybe 8, 10, and 15 years, the tissue and the bone continue to remodel. You're getting a lot of bleed through, thinness, and some bone remodeling as well.
And that seemingly little piece of tissue, which you can see is a round diameter, not very much, but quite thick, put into this area, remember, is at the zenith of your restoration, where the tissue tends to get pushed and get thinner over time and then recede. So that little tissue is all critical for me to be able to maintain that transitional zone. So we never throw it away.
So what David's talking about is now this implant's put in, and that tissue that was over the top, rather than being discarded, has been placed underneath, right in front of where his restoration is going to be. He's now going to be working in a situation with these peaks of tissue that have been undisturbed through this surgery. The only suture was a chromic gut suture where the screw was removed. Minimally invasive transitional appliance can now be replaced by David with composite. We send the patient for a few weeks to heal. This is how he heals, and David now can work in the restorative phase.
So we've made a provisional restoration screw retained. You can see us molding, sculpting that tissue till the transitional zone mimics that, or fairly mimics it, at least in harmony with those of the contralateral or adjacent teeth. And you get a sense of where we came through, the depth as well as the two-dimensional aspect of this. And then when I get the restoration in, understand that we've come from up there to lower, more coronal than the adjacent teeth. So he's really done an incredible job of reconstituting that for me, and I anticipate a nominal amount over a period of time of tissue development around that recession and forming close adherence to it. And obviously, a gentleman who's quite delighted and continues to aggressively pursue a multitude of supports, including polo.
This is 5 years post-op. Patient comes back in to see us. He actually lives in Dominican but has family in Atlanta, so comes back once or twice a year. Comes back in to see us, 5 years, everything's looking pretty good. A kind of interesting thing happens, as we all know. We kind of follow him over time. When I take a look at these cases, people always ask me, how much time between surgeries? I think it's important. David asks me, the patients ask me, how much time are you going to wait? How long it's going to take? And I think as a general rule, and I give this only as guidance, every surgeon in this room may have their own particular time regimen. This is mine. I try to base it off the science that I've read. For autogenous blocks, I typically wait about 4 months. With guided bone regeneration, I like to wait 6 to 8 months to really give that bone enough time to consolidate. With bone morphogenic proteins and tie mesh, which I'm starting to use more and more on very large critical size defects to avoid autogenous harvest or large harvest, I wait even longer, 8 to 10 months, because that bone seems to, although it regenerates, it seems to be a bit soft. So I wait a little longer, and with allogenic blocks as well, 8 to 10 months. So if you're going to use cadaver bone as a block, I would tell you to wait longer. And also, if you're going to try to use it for vertical augmentation, I have seen a lot of remodeling and resorption of the vertical component. It seems to be much better, these blocks, for horizontal augmentation in the maxilla when you combine it with growth factors. So the patient comes back to see us, says, I need to come in and see Dr. Garber. He's in town. And lo and behold, David, what do you find out?
Well, he was first called me with his friend who'd taken an x-ray, and they found this tiny little fistula up there.
The first thing David says to him is, I'd like to take some pictures because the implant that we did 5 years ago looks great. So the guy goes, I'm having pain on my tooth, and David pulls out a camera. I said, wait, I gotta take the picture before we manipulate it.
So we take a picture, and in taking the picture, obviously notice this. Looking on x-ray, it's kind of difficult to see anything definitive, and we did a CBCT so that we get a whole lot more information. Maurice happened to be in Santo Domingo, and I asked him, would he go and see the patient right out in Santo Domingo and determine what next to do, and made a treatment plan out on the beach.
I was actually in the Dominican Republic lecturing at the university when this guy called David and sent him all the records. And now these days with these silly phones, All of a sudden, the guy's calling me. David's sending me the records from another dentist in Punta Cana that saw him, and I'm at a restaurant. I just landed. I'm trying to interact with him on what needs to be done.
After 3 scotches.
No, that was it. That was afternoon.
That's what I said, only 3 scotches.
I try to leave that for later in the evening. And in that part of the country, that part of the world is rum. Rum is good there.
Rum.
So he says he's in pain, he's uncomfortable. They send me the cone beam CTs, and I said, listen, you know, I'm not very comfortable not working in my office. I don't know what's going to be needed. It looks like you have a fracture and some bone loss, and he wanted me to treat him there in the Dominican Republic in somebody's office. If that ever happens to any of you, don't do it. Not because they're not wonderful people, they are. It's just that, you know, it's not your assistant, it's not your staff, it's not your chair. I'm like really particular about that stuff, so I wouldn't do it. He tried, he was very nice, and then he said, I'll see you in Atlanta. I put him on antibiotics, he flew in with this fistula. And when you take a look at it again, kind of interesting. If you look what has over 5 years, what has happened, we get some recession and breakdown of the ACDM that we did. To be truthful and honestly, I was a little disappointed in what's happened, but this could be also due to some of what's been underneath this fracture. We have a little bit of recession of the canine still, but look at how this is held up. The implant, with the bone and tissue and all that stuff that we had going against us, the implant has been the one stable factor in his whole mouth. Pretty amazing. If you really want to look at a person, everything else around the implant is breaking down. And which reminded me of a case David had that we treated in 1992 when I first came to Atlanta. There was a lady, I always talk about this case. She came in to see us and she had quite a few problems, but she was missing a front tooth. She said, please fix my front tooth. I need it for work. We put an implant, central incisor. We didn't see her for 13 years. She ended up on our book. This is a true story. She came in, she had no teeth in her maxilla except the one implant that we put in 13 years earlier. I said, she's a unicorn. So, first thing I would tell you, and this is right off the bat, don't work outside of your office unless you're comfortable. And second is, don't just trust your cone beam CT, definitely don't trust your PA films and bone sound. Take your probe, nice and thin periodontal probe. For your oral surgeons out there, buy a few of them, really thin ones, okay? And stick the probe through the sulcus until it touches something hard. Hopefully it won't be in the nose. But really and truly, you need to be able to kind of map out where that bone is and how far that infection has gone. It is important, and it really does base it for me how my flap design is going to go. Because if I'm missing bone on this implant or on this tooth, I may use a tunnel or I may spare this papilla in my incision. There's a lot of things that go into it. Take a look at the cone beam CT. We see the fracture. We see where the fistula is. Unfortunately, it's a vertical fracture. I can get the implant to be coming out through the cingulum, which I prefer, always placing my implant towards the palate, as we talked about earlier. And lo and behold, here's the fracture, and the tooth comes out in a few different pieces. So here's the teeth. Second big thing is curette the area aggressively with a serrated curette. Make sure that there's nothing left behind that's soft. Irrigate thoroughly. And if I have enough bone to place and stabilize my implant, I like to pursue a immediate placement of an implant. In this case, we're going to go ahead. He has had that other implant placed 5 years ago. I talked to David, and he says, I'd like to be able to manage this soft tissue to bring it down a little bit, and possibly also, I want to be able to maybe have the ability to alter any kind of tissue issues, tissue color issues. So this was a case for us that we started to implore and utilize the anodized new version of the implant, the Genesis implant at Keystone. So you can see how far palatal we actually come. Don't worry about where the bone is on the labial. Place your implant to come out through the cingulum access. And as we do that in this system, which is very, very nice, they have those little analogs that you can put in for each diameter, which I like a lot, because a lot of times, as a surgeon, you can plan all you want on cone beam CT. I can tell you there are times that you have to do it, what Peyton Manning used to do, Omaha, and change the play. For those football fans in the audience, obviously not a lot of football fans. But You need to be able to change and alter your plans. Sometimes the best laid plans need to be altered, and you need to be able to do that. So having this in the system was a great idea, and it fits beautifully into the osteotomy sites. I can take a look now for David. Is this going to be enough space for David to work in? Is that distance adequate restoratively? Is that distance going to be adequate surgically?
And this is very important to me, the 3D spatial relations, because as I see those different blue indicators coming out, I get a sense that the subgingival aspect of the restoration is going to be much more on one side, say the mesial, than the distal. I get a sense of how I've got to develop the undercut on the labial surface so that tissue doesn't get pushed up. So do look at those pictures, and those little pieces are in the kit. It is a restoratively driven kit for a reason.
So we can go ahead and try out the 3 millimeter, make sure that we like where we're positioned, and then make our decision through these analogs. Are we going to go with the 3 or the 4? And then we decided to increase the diameter of the implant only based on that information. And luckily for me, David was in the office. I actually like to get up if I can, or send one of my nurses and Dr. Garber come in, because the last thing I need is for David to tell me later, why'd you put that diameter implant in? It doesn't work well. It can make me difficult for the restoration. David can come in and say, you know, I can work with that. If the lab tech is in, he can take a look and say, that's fine, I like it. It's going to be something that we can manage quite well. So I think having that option is very critical. So we can evaluate that on the day of surgery when the implant's going in. Now, I do have, where that fistula is, I do have a little vertical kind of dehiscence here. Not a fenestration, but a dehiscence. And you know, you have to make your decision here how you're going to address it. David was kind enough to tell the patient before he flew in from the Dominican that more than likely he would be walking out with an immediate temporary restoration. So he definitely put a lot of pressure on me. I'm going to try to use bioactive modifiers. This is PRGF. I use also PRF, plasma-rich fibrin, or plasma-rich in growth factors. So we take away about 90% of the blood that's predominantly plasma, and we keep the less than 10% that has all the growth factors in it, and we then utilize that inside the site. We then use the fibrin, and I place the fibrin inside the site, and I use it as an autologous growth factor-induced membrane. So what you're seeing now is pushed up against that labial plate, against that tissue, are multiple layers of this fibrin membrane. And then against that, I'm going to then bring sticky bone. This is cadaver process, cortical cancellous, small particle size cadaver bone. And I'm going to place that bone that's mixed with the growth factors, so it's sticky, doesn't fall apart. I'm going to place it against the fibrin. So I'm going to have basically a membrane, or autologous membrane, and against that membrane, I'm going to place the bone, and I'm going to pack it against the labial wall. And then I will introduce the implant, the Genesis implant. Here's the anodized surface that David wanted, just because of this tissue may be an issue for him aesthetically. And I'm going to introduce this implant behind that graft, towards the lingual, towards the palate. I'm also, this is very critical for us, I prefer implants with what we call wettability. The surface for us has to be hydrophilic, not hydrophobic. I want a surface that's going to attract blood, and in this case, growth factors, PRGF. And you can see how this entire body of this implant, when we use the syringe to place the growth factors on the implant, it's completely wet and maintains it. And I can then introduce the implant, as you see here, to the implant site. If you take a look at this from a primary stability standpoint, you're going to get your primary stability here, the bottom to the middle surfaces, less primary stability in this area where the loading surfaces are, and then the anodized surface here. Secondary stability, as mentioned earlier, but most importantly, when you look at the hydrophilic surface, which is part of this implant, that's going to give you your secondary stability. Primary stability is the macrogeometry. Stability comes from this kind of wettability, which attracts cells. So that's the cellular or biological stability that comes from osseointegration. This is mechanical, That's actual scientifically the biology of secondary stability. We then place the implant, we drive it into position, and once the implant's in place, the bone is here, the fibrin's here, and this has been all cleaned out. I can hand the case after I place the healing abutment in position. I have one rule that I use for immediate provisionalization. If the implant doesn't have at least 40 Newton centimeters of initial stability, if you don't have an Ostel reading, if you're using radiofrequency, if I don't have an Ostel reading of at least 62 or above, I will not allow David to proceed with immediate temporization. We don't load it, but I wouldn't even allow immediate temporization. I want good stability. In this case, we got very good primary stability at about 45 Newton centimeters, and I told David he can go ahead and provide this patient with an immediate temporary restoration.
And so he puts in the interim restoration just to hold it over until I walk in the room. And now I want to put in a temporary. I'm going to load it immediately. Not really load it, but provisionalize it immediately. This is a copy that I had made of the original tooth, just in acrylic. I put in the temporary cylinder in position and then cut this out until it fits perfectly over that. And then I want to get it in optimal position. The best way to do that is with an index. So we make an incisal index in an acrylic resin. And now I know it's in the exact same position passively as it was originally. So I know I've got that tooth in and I've got perfect control. As the acrylic sets and it takes a little longer, I'm not holding it and jiggling it and turning and talking to people and then have to grind it. It will go again perfectly. I don't want to disturb anything down that site. And remember, that was a big hole. I don't want to have any acrylic in there. So we put a little rubber dam on it. I also use some of the fibrin, which is like crazy glue, the thick one, and it seals up everything. I put it down there. I put it on the end of the temporary restoration, and once it comes back, slide it up into position and torque it down. Now you have an option. At this stage, if you wanted to, that's why I've got a question mark, you could actually take an impression. And I did it in his particular case because he comes from Santo Domingo. Put another piece of rubber dam on while he was being finished up in the lab on the temporary. I put in impression coping. I've got the still self-same index that I used to put the temporary on. Now I can relate this to the index by just putting a little dab of Duralay on, pull it off, it all comes off. I can put this back on the model, reposition an analog on the base of this in the model in the exact same position, and we can go ahead and have a temporary made up, and you can see where the access was. We then go at the end and put a little more fibrin on, and you can see Maurice tucking this up underneath the tissue. It seals it all. So you've got a prosthetic socket seal, which is good, but you've got it here with glue on it. So it's a socket seal plus. And you can see as this begins to fill in, and we remember under contoured that to hope that that tissue will come down somewhat.
One of the most important things from a surgical standpoint for David actually helps me in this case, because you saw this gentleman had a little bit of recession and gingival margins weren't even between the tooth that was fractured and the implant. So David was kind enough not to add any contour to this area on the facial, hoping that this tissue then can travel and move coronally to give us a better symmetry with the adjacent central implant. So you can see this very, very critical area here. This peak of bone right here on this tooth. Invariably, we were lucky enough not to damage it during the process. So from a surgical standpoint, when you're taking out the teeth, I like to use anything that's minimally invasive, whether it's a periotome, a piezotome, whatever you like to use, but don't lean on that bone interproximally. You can see here what I try to give David is something that's going to support that papilla. because if you damage or break this bone that was here, and it's not, and it's broken or damaged here, and you've traumatized it during the extraction, you may in fact end up losing the papilla and getting a black triangle and aesthetic issue. So the patient comes in and is able to have the surgery, tooth removed, and an implant placed, and an immediate provisional with good stability using this new anodized Genesis implant. It's been a nice story for us. And what we wanted to do with the first part of our lecture was really to introduce to you some of the concepts of managing these critical interfaces. We started by prosthetic means and artificial gingiva. We then showed you a few cases of how we work together surgically to provide the restorative team, David in the lab, the ability to mold and shape the tissue in many different ways in an aesthetic zone, and really taking focus of that transition zone. When we come back from the break, we're going to move into some new concepts related to digital, full arch, and a concept that you may not have heard of, but I'm going to just try to get an idea before you go get coffee. How many have ever heard of partial extraction therapies? How many have heard of socket shield? This is a good group. We're going to talk a little bit about that and what the latest research and science is on that as well. I thank you very much for your attention. I look forward to seeing you after the break.
Thank you.